I think David just said to me, can we actually have the first session as an NDIA-free zone? And not a bad idea. It's why we've called this one The Future of Respite in Mental Health, because the issue obviously goes much more broad than just the question of what's happening with the NDIA and the NDIS and psychosocial disability. We will come back to that in the second session with Tina and Liz when we're talking about how to make the NDIS work for people with mental illness and their families. But in the first session, we've got David Meldrum from the consumer group, the Mental Illness Fellowship of Australia, and Jonathan Harms from ARAFMI, which is a carers consumer group in New South Wales. And they're going to talk to us about the broader issue of respite in mental health. So welcome to them both.
Thanks, Chris. Yes, I'm not going to mention that scheme for 15 minutes. Because I don't need to. What's happening here? This is not my... Yes, I'm sorry. Looks good, but it's not mine. Thank you. I'm really gratified to see a decent crowd here because we often are fringe dwellers in the wider disability world when working with people with mental illness and their families, and it's great to see a good turnout here. In some ways, listening to a number of sessions during the day, I realise that this is going to be like Respite 101 because so many of the issues are the same across so many areas. But there are some distinct things about working with families where serious mental illness is an issue, and I hope they'll come up as I go along. Sorry, that's who we are, the Mental Illness Fellowship of Australia. All of these organisations from Townsville to Hobart to Perth are largely focused on working with individuals and families who are experiencing severe mental illness. So the NDIS target, I didn't mean to. That target group you keep hearing about of 57,000 people, that's our ballpark, our main ballpark. The types of ways that I'll go back a step. There's a sort of phrase that quite a few of us use in my line of work, which is if you're not working with the whole family, you're not doing your job right. And so working with carers is part of the wider work we do with families. So, for example, we think a lot about how to get to families who need help because it's a huge marketing problem for all sorts of family services in mental health. People do not know where to find it. They go to a GP, they may get a referral to a psychiatrist, they will almost never get any mention of the community support services that are available to them, including Respite. They go to an emergency department, they'll never hear about it. They go to even a psychiatric hospital admission, they'll never hear about it. So how do they get to hear about it is a really significant issue. One of the things we've done recently across our network in Australia is put on GP's computer page, front page of Medical Director and Best Practice and ZMed, a link so that if a patient asks about schizophrenia or bipolar, they'll see what's available and our fact sheet will come up, which includes a very clear link to where you can get help near where you live, including carer and respite services. In fact, in the last 3 months, GPs have downloaded that 80,000 times. So we think we've actually struck a good way to connect up the parts of the system. We provide a lot of information at the front desk. Education, group education programs, you would have heard of a number of them. There are things called Carer Assist and Family Assist and Wellways and a variety of other programs around Australia. They are extremely highly valued by carers and by families. They form lifelong friendships in those groups, and that impact of a combination of really good, accurate, up-to-date information and the I thought I was the only one syndrome works a treat, and it works just as well in the area of mental illness as it does with all sorts of other health and disability issues. Referral, when it's done well, is highly valued by carers, and when I say it's done well, we collectively have a view that you need to do a warm, personalised form of referral, not here's an address to go to. We stick with people until we're sure they've got to where they need to go. Respite is where the rubber hits the road in terms of resources, making respite work. It tends to be the most complex for organisations to deliver, and I think in many ways, apart from informal respite, volunteer organised respite, it was the sort of last taxi off the rank in terms of mental health services in recent years. It's a contentious topic, as somebody mentioned this morning. I think it was Bruce Bonnyhardy mentioned it this morning. It can be still quite contentious. People see respite as a sort of tiny offering from charities to relieve their suffering for a few moments, and that tends to get people's back up, and so it can be a sensitive topic. But nonetheless, it's the dominant language that we all know roughly what it means. I'm talking from a Mental Health Council of Australia carers report in this particular slide from, it was done about 18 months, 2 years ago now, I think it came out early in 2013, where we got a whole lot of people and asked them whether they were using respite services when they were eligible. These people were all eligible to do so. And only 18% had used respite services. And the reasons are there. They didn't need it, or they said what they needed wasn't available. Now, the they didn't need it stuff will be very familiar to you, I think, whatever area you work in. It was usually, I want you to find better services for my son or daughter before you start worrying about me. And that remains the focus of most interactions with, particularly with parents. The 27% who said what they needed from respite is not available, we'll come back to in a moment, but as you know, the issue of the menu of respite, meeting people's real needs, is a big issue. This comes up particularly strongly with severe mental illness, particularly where people have behaviours where they themselves are not safe or they can make other people around them unsafe. 23% were saying, I couldn't leave my son or daughter with a respite worker because there would be a disaster of somebody getting hurt or them running away or whatever. Unfortunately, this crops up even with big agencies that have well-funded respite programs. They'll say, it wouldn't be safe for our workers to be alone with your son or daughter, which is a great thing to hear when that's what you do all day. And 11% had never heard of the concept of respite. And you'll notice that 5% said that wasn't available in their area. So it's pretty widely available, even if it's in short supply. This is a survey that was done late last year, early this year, funded by Roche Pharmaceutical, I think, where they got something like 200 people online and in interviews, all experiencing, all to do with schizophrenia, it was. The feedback came that most of what was available to people only worked if they were comfortable with group settings. So one-on-one was very hard to find. You all know the economic drivers of that. They frequently come across facilitators who just don't seem to understand you just can't leave the consumer alone to come and do a respite, etc. Well, as I look at this, I think, gosh, you all know all this. The no one-on-one services, the no counselling options, is actually a wider problem. There's a program operating out in Dubbo called Partners in Recovery, which is really, as part of its job, is looking at what are the services available to families where mental illness is an issue, and the service that's gone missing, unbelievably, is one-to-one counselling. Can't find it anywhere, not just for their son or daughter, but for themselves. It's become too expensive to do. And so one of the things that Partners in Recovery program is doing out in Dubbo is effectively doing a whip round of all the relevant agencies to try and increase the amount of one-to-one counselling available in the area. Doctors don't do it, psychologists only do it for $190 an hour, etc., etc. A real lack of practical help is brought up again and again in every survey you read. The really big issue often is domestic duties, and respite that provides help with domestic duties for the sake of the carers is quite hard to find. Carers find it very difficult to ask for respite and to explain it. Now, to some extent, this is self-stigmatisation. People report that they feel stupid asking for someone to help clean the house when they're perfectly capable of doing it, but just reaching breaking point and needing to get a break from that may sound like a reasonable request to you or me. To a lot of carers will self-criticise themselves into the point where it's a very difficult, fraught situation when they're asking for that help. It impacts on their pride and their self-esteem. It's very difficult to ask. And that final point people raised is telling you that warm personal referrals are not happening everywhere. People just get told, we don't do that anymore here. I'll leave you to read those. Those are very common experiences and examples of what I was just mentioning. Programs like Respite come and go with great regularity. Our worldview as providers tends to be measured in months and years. The worldview of carers is viewed in decades, and programs that come and go every couple of years are almost not worth having in a lot of cases. That's a very frequent experience. I've mentioned before, unable to get assistance outside of a group environment, unable to get crisis help, lack of adequately trained experienced support workers. Again, I blow our own trumpet a bit. Across our group of agencies, we've concentrated very hard on all our carer support group programs being either directly facilitated by or co-facilitated by a peer, a carer who has a person in their family with a severe mental illness. That's the way to get the skill levels up and to get the relevance up. There are so many reports of programs being started on a wing, the funding being granted to somebody in a country area where they can't find decent staff, and they end up. I know of one recently in the Northern Territory where it was run by backpackers, the Respite program, who stay on average 3 months. That's no way to run a Respite program. I would access them if I knew where to find them. I'll leave you to read these. Suggestions to improve services. Easier access to information on the condition. This is just a roundabout way of saying, where do I get easy access to people who know what they're talking about? And as I said at the start, we've got a huge marketing problem in community mental health services. We think we're great. We think everybody's heard of us. In fact, most people in need haven't heard of us and don't know where to start. Asking for much greater flexibility with small bits of respite, if you like. These things seem to be so hard to do. We live in a welfare system and a health system, many of us, which is asset rich but cash poor. You can't even buy a person a cup of coffee and be sure of being able to get it back from petty cash. And that runs to the way we do a lot of our programs too. The small flexibilities that need easy money to use when you need it are hard to find. So that sort of practical help, small opportunities, individual carer support coming up again. That's all stuff that's challenging, but I just wanted to mention a good example towards the end here. The Mental Illness Fellowship of South Australia got money from Commonwealth Carer Respite about 3 years ago, and they've done 100 residential respite programs, and it's been a screaming success. It is heavily driven by peers being the people who design the programs, and those are the comments. I'm on the board of that organisation, and You get many complaints in delivering any human services. Never heard a complaint from that respite service. It works a treat. I'm looking forward to the future here in general terms, thinking about what the world ought to look like for people who are looking for respite. The first thing is looking after someone with a serious mental illness shouldn't mean poverty for the whole family. This is the Carers Victoria Invisible Care report from last year. This is a big sample of people looking after a child with severe mental illness. There's what happens. 58% of them have had to ask their friends for financial help. As I go through each of these last 2 or 3 things, it occurs to me it's almost like getting a half dose of the mental illness. Your mental health gets damaged, your physical health gets damaged, your economic health gets damaged, your relationships get damaged. Caring for somebody shouldn't mean experiencing poorer physical and mental health than the rest of the population. This is a 2014 study from the UK. This is where I thought I was doing Respite 101 for most areas of disability or physical illness. These stories would come up across the board, I'm sure. And in 10 years' time, as somebody who's already got to deal with the difficulties of someone you really love living in your house, most probably, with a very severe mental illness, it shouldn't have to also mean being isolated from society by prejudice and fear. Unfortunately, that's what happens a lot of the time. I don't need to tell you that carers should be embraced and supported, not stigmatised and isolated, but that's what happens all too often. Thank you very much.
Good afternoon, everyone. My name's Jonathan Harms from Mental Health Carers ARAFMI, New South Wales. We're the peak body for carers of people with lived experience of mental illness in New South Wales. And I'll just commence by acknowledging the traditional custodians of the land and their elders past and present. Thank you very much for having me here today to talk about the future of respite in mental health under self-directed disability support schemes. I should allude to the fact that there are 2 Commonwealth-funded schemes with self-directed funding that are looming large in the mental health space at the moment. The one is the Ndis, which we've heard a little bit about today, I believe, already. The other is Partners in Recovery, which is actually across most of the state. It was funded through Medicare local districts, which largely correspond to 1 or 2 LHD areas, and it's designed at promoting collaboration between agencies and community managed organisations that support people with lived experience of mental illness in the community, and that is another self-directed funding scheme. So, talk about Respite 101, I will kick off with the very self-evident fact that respite in the traditional sense as being support being provided to give the carer a break to enhance their caregiving capacity, their ability to keep on caring, looks very different in a self-directed funding scheme because, of course, respite in that sort of a scheme is about the services that the consumer wants to receive, which incidentally relieve the caring burden on their informal support networks. And that's a very important point. I've actually heard that one of the relevant ministers has actually said that the whole scheme is effectively respite for carers when it comes to the NDIS, because it's all about supporting the person with the disability and helping take that burden off their families. So that's an interesting take on it. We would argue that there are some specific needs to support carers to enable them to have their own health and well-being sustained that might not necessarily fit into that rubric, and we'll examine that a bit further during this presentation. However, it is important to note, because I will be referring to the individual budget scheme which has been introduced in England, which is a similar self-directed funding scheme, that both that scheme and our NDIS and Partners in Recovery are looking, at least initially, to focus mainly on the person with the lived experience and have not dedicated much resources to specific carer support. Although I believe, listening to Dr. Karen Jones's excellent presentation yesterday at the Social Policy Research Centre on this subject, that the English scheme has actually revised that in light of findings from the pilot to a certain extent, which is good news but hardly unexpected. So the carers experience in the UK, which I'd like to allude to because it's been implemented for some time. They actually had another scheme where you could cash out the supports that you were receiving, and that was effectively moving towards a self-directed scheme. So they've had a couple of goes at this in the UK. A report, however, has been done on the individual budget scheme by Dr. Jones, among others, through the University of Kent, which was entitled, "Can Individual Budgets Have an Impact on Carers and the Caring Role?" So this scheme found that the introduction of cash for care schemes, such as individual or personal budgets, was associated with positive impacts on carers' reported quality of life, and when other factors were taken into account, with positive social care outcomes. And that also found that these outcome gains were achieved despite no higher costs being incurred by the public purse, thus suggesting that individual budgets for service users were cost effective, and cost effective for carers as well. So that was the initial finding. Oh yes, I will come back to this, but I did actually have the opportunity to discuss with Dr. Jones yesterday some of her findings in that report, and I would just say that it's not going to be exactly the sort of report that allows us to compare like with like, for example, because the English scheme you had to apply for and be accepted into, and that meant that the sample, essentially there's going to be a high level of self-selection for people who are more on board with receiving support. And in the mental health context, that is not always a given, and particularly if people have low levels of, if they experience frequent periods of incapacity for decision making, that might have actually meant that that person was not accepted into that scheme in the UK. Now, obviously, our PIR and NDIS are squarely targeted at the most disabled people, including the 56,000 in New South Wales, with most severely disabled by psychosocial disability. So we would, in fact, expect that there'd be high levels of participants with incapacity from time to time, because they are the most unwell people affected by mental illness. So another study has been done, which I will refer to, which is the Carers New South Wales report on the experience of the NDIS at the Hunter trial site. I've given the whole title there, but I haven't quite put it in the apostrophes to make that understandable. The carers, it found generally similar outcomes, that carers of NDIS participants were likely to experience some benefit from funded supports, and also that the rules did allow some specific funding for carers, but only to help sustain these informal care arrangements. So it was really to help them keep on caring. It wasn't really aimed at supporting their ability to do so in some ways. So the English study found that carers providing assistance to service users with a mental illness were less likely than other classes of carers to participate in care planning. This was an important factor because in the discussions yesterday in particular it became apparent that the degree to which schemes allowed flexibility and self-determination of how funding was spent was quite closely related to the effectiveness of those schemes and the outcomes that they were achieved. So more flexibility was associated with better outcomes. And obviously involvement of family and carers and significant others in that planning process, which might be very important for people with periodically impaired decision-making capacity, would be an indicator of the degree to which the carer and consumer wishes in some ways had been taken into account. The principal cost to the carer, it was found in this study, was the opportunity cost of time spent on caring. It was found that the carers of individual budget holders spent on average 81 hours per week caring, compared with 72 hours among carers in the comparison group, although this was not statistically significant. Now, the reason I mention this particular granular piece of information is that generally the report said that carers benefited and had to spend less time caring. But when you actually drill down into it, you find that there was, in fact, a slight increase, but it wasn't statistically significant. So that becomes more important because when we look at the Hunter example that was looked at by carers, New South Wales, we find that generally speaking, the experience of carers was also to have to spend more time in their support role because they are expected to help source the support that their loved one needed. And that meant that there was often a lot of administrative and paperwork type work to be done, which a person with a significant psychosocial disability might not be in a good place to manage on their own. So carers had to step up and do a lot of that extra work, and we'll see how that becomes more relevant as we go forward. However, the NDIS, like the English scheme, is not about carers. Unlike the English scheme, it does not allow carers to be paid for providing care if they are informal carers. Now, I say that they do allow that in the English scheme only if you don't live at the same residence. You can get it in those circumstances, but it has to be a very special case. So once again, generally, the informal unpaid care that carers are being provided in both the English and the Australian schemes, they expect to continue to be provided on an unpaid basis. And that's an important element of how they understand the scheme will work going forward. Carers of people with disability in the future may no longer have access to Commonwealth-funded carer supports outside of the NDIS, and as they're expected to continue their caring role, you can understand that that's going to be a potential issue going forward. The Carers New South Wales report, I'm just quoting a paragraph out of it here because I think this is generally mental health, psychosocial disability is only a small part of the people who will be supported by the NDIS, but this is indicative of what's going to happen here. Funded supports will be available to an estimated 460,000 Australians under the NDIS. However, the numbers of Australians with a reported disability, even those with a profound or severe core activity limitation in the target group who need assistance with at least one activity, is much higher than this, at approximately 1.4 million, or if you look at just the more severely disabled people, 710,000 respectively. Now, I should say that there is some suspicion that the people with a very serious and profound mental health disability is also a bit underestimated, even from this. So, as you can see, there's a potential for a lot of people to be left out of this. And if you're not in the NDIS, you're not going to get Commonwealth benefits otherwise. That's a problem. The way the in which the NDIS is designed is not to duplicate things that people are already getting for free, and there's an expectation that this care will continue to be provided. Now, I'll just throw in the ABS statistics about what care is being provided currently for free in the community, and you can see why the government hasn't raced to replace a lot of care with paid support. 60% of carers provide 104 hours of caring a week. That's 2.5 full-time jobs, I think. The annual replacement value of that care, and I should say that this report's about 3 or 4 years old now, is about 40 billion per annum. A lot of the people who are actually providing this care to people with lived experience of mental illness are not currently receiving any benefits, because the periodic nature of mental illness means that it's much more difficult to qualify for those support, because you don't necessarily have to be on hand all the time, but as we've heard, you do have to be on call. And that's actually quite inconsistent with paid employment in a lot of circumstances. There have been suggestions, including in the McClure report, that there will be a lot less need for carers to receive benefits as an alternative to employment in particular once the NDIS is up in place, because of the respite nature of the whole scheme. And we think that that is going to leave people potentially left right out completely, and that is something that we need to be really strongly advocating to make sure doesn't happen. The Commission of Audit also targeted 15 key areas for cuts. Now, I know that the budget has moved on, or failed to move, thankfully, in some areas, but some of those areas do include the National Disability Insurance Scheme, carer payments, and the Disability Support Pension, to just list 3 in sequence there, that will be of particular interest to our groups. Now, as you can see, I don't know if I've actually picked up entirely the right version of these slides, because there was a particularly important slide that appears to be missing, which is the one where the Minister, in moving and passing the NDIS Enabling Act for the State Government of New South Wales, made it clear that after 2018, the State Government is going to get out of disability support. Now, the State Government in particular funds the Family and Care and Mental Health Program, which provides direct support to carers of people with lived experience of mental illness. We're not exactly sure, we don't think that that's going to be in scope, but if you took the Minister literally, then that would mean that there's going to be a lot of people with fairly significant needs for support who are going to be left right out entirely. And we can also say that from the general atmosphere that has been created around the provision of welfare and certain classes of benefits by the government, that there does seem to be an enthusiasm for cutting as many people off as possible, and we don't know whether that's actually going to result in positive outcomes for a lot of people with significant disability, and we certainly can see how a lot of money has been, carer support money has been placed in scope for the NDIS, but that there are no robust mechanisms for actually making individual carer assessments and then delivering that scheme. So I think I've gone on for quite some time. I'll just conclude on one positive note, which is the fact that it appears from my discussion with Dr. Jones yesterday that they are now doing in the English scheme an assessment of the informal support networks needs when they do the assessment for the participant in the individual budget scheme, and they are allocating some support to allow those informal supports to be supplemented and made sustainable for the individuals concerned. It is still part of the participants' assessment, which is logical because after all it is a disability support scheme, and if they have other support needs then that might be part of another scheme. But at least that is something that has changed in the English model, and it's something that we would hope to see change here as well. Ideally we would like to see some separate assessment both in Partners in Recovery and NDIS of carer and informal support network needs as part of that formal assessment, and the carer to be given some autonomy in how they actually spend that portion of the assessed budget. But otherwise, there is certainly the need for some dedicated systemic advocacy over the next couple of years to ensure that our mental health carers and carers generally don't get left out of these positive, otherwise rather positive developments. So thank you very much.
Thanks, Jonathan. What we're going to do now is take just a couple of questions of Jonathan and David before we move to Tina and Liz. So I'm actually going to rove around and do the quiz show host thing and get those questions. I just want to say I like listening to both David and Jonathan, and I know when we're going to get to Tina and Liz. Sometimes when I think about the challenges facing people with lived experience of mental illness and carers and families and what's happening with systems, I kind of get overwhelmed with it because it is really difficult. And then I hear these guys speak, and I'm sure we're going to have the same experience in a little while, and I think that may be the case, but they've sure got some great advocates doing that systemic advocacy, and it's really good to hear. So any questions of either David or Jonathan? Raise your hand for me so I can see you. Yes?
Is it on? Yeah. Hi, this is more of a comment. I work for a Care Support, an agency in Adelaide. We have both NRCP and HAC funding. And one of the things we find is that if carers go to Centrelink and are rejected, they think they can't come to us. And obviously it's mainly carers of people with mental illness that happens to. So we do know that we've got a big extra job to try and make sure that carers out there do know that they are still eligible for services from us.
Yeah, okay. And I guess one of the issues for us over the course of this conference is what the Commonwealth does around carer support is really important to all of us in this conference, but particularly to carers of people with mental illness or chronic illness, because how that's going to interface is really uncertain. Any other questions or comments? Yep, got one up the back there.
More of a comment again. We're a mental illness fellowship Victoria based in Tasmania, and the family support services program there. I think one thing that we find is that the term carer can be a bit unfortunate, because what people say is that it's an extension of their role as a husband, a wife, a parent, a sibling, and so they don't actually see their role as being a caring role. It's being with a loved one. So when services, are entitled carer support, they just don't feel it applies to them because it's a part of their role. They're not in a paid caring role. They don't have a carer's allowance, that sort of thing. So in marketing the programs, it becomes quite tricky in how to get the message across that these services are for you.
Yes, that terminology can often be quite tricky because people do just see it as part of their natural relationship with their loved one, father, mother, brother, sister, son, daughter. But on the other hand, it is necessary to have some term to identify the people who are actually providing the specific individual support, because obviously they are the ones that we need to direct that additional assistance to. And I can tell you that we regularly have discussions about what alternatives to carer might be, and if we ever come to a conclusion, I'll certainly let everyone know.
Any other questions or comments? Yes?
Hi, Vanessa from Ageing, Disability and Home Care. I think that we're seeing an increasing number of dual diagnoses with our clients, and with their predominant disability being intellectual, often their mental health support needs are not addressed appropriately, or they're not eligible for mental health services. I'm just wondering if you're aware of any work that's being done to help address that as we progress through to the NDIS.
We live in different parts of the country, so we may give you different answers. So, I think that, by and large, the sector that I work in has failed to address that. And where we occasionally have a participant or a client with an intellectual disability and a severe mental illness, it's been a bit of a fluke of a pathway. It remains an unfinished bit of business to us to start reaching out to people we haven't reached before, and people with intellectual disability is an obvious and significant group.
Thank you. Look, in New South Wales, we're lucky because we have the Hunter launch site, which is the adult mental health launch site, and it's got a Partners in Recovery consortium in place there. And there have actually been some good stories to tell about them actually breaking the rules a little bit, actually busting people out of hospital, getting them accommodation in the community, and providing some of those sort of wraparound supports that people need. Dual diagnosis tracks very closely against personality disorder in the way it can be understood to be a type of personality disorder in some cases, or a lot of cases, because it's a maladaptive coping mechanism. And as we know, the right way of treating those sorts of disorders is psychological therapy in the community. And I don't think it's coincidental that the two things which seem to come up most frequently as services that people pick for themselves are counselling and also that sort of case management role, helping them get between the different services they need, personal assistance and that sort of thing. So I'm not aware of specific programs to do it, but I think that people are picking it and doing it for themselves, and I certainly hope that that's one of the positive developments out of this self-direction. Okay, Janine.
Hi. Just following on from that, I'm Janine with the Schizophrenia Fellowship. This issue of people with a developmental disability also having a mental health issue, I think, I agree, has long been overlooked. And often it is an issue of, I guess, support workers, organisations being able to recognise, that I think people with an intellectual disability often have a much higher level of particularly depressive illnesses and also mental health illnesses that are not being recognised. The Schizophrenia Fellowship has a training arm, and a part of our training is really helping service providers to be able to recognise that correlation between intellectual disability or developmental disability and mental health, and how to resource workers to be able to work with people who have this experience, because it's extremely difficult for someone who doesn't have good cognitive ability to be able to express what's happening for them. It's difficult enough for someone with lived experience to be able to get us to help to understand what it is that they actually live with and what that experience means for them. So if you then take that into an area where someone has an intellectual disability and lesser cognitive capabilities, how can they really indicate to us? And so often, in the experience I've had in the working field in many, many years, is people that gets to be seen as, I guess, a difficult behaviour. It's often not a behaviour, it's someone responding to something they don't understand that is not being addressed on their behalf, and there's not enough professionals, I think, in terms of your GPs, your psychiatrists and that, who really try and specialise in that. I know there are certain organisation, people that really try and work with that, but that field is very limited, and so often people go without their mental health needs being addressed if they also have other disabilities that are perhaps the primary disability. Also underpinning that has been a long-standing history of where mental health services and disability services have not spoken to each other, and that's only just starting to be addressed.
Yes, I'd certainly agree that it can be very difficult to get physical health issues addressed if there is a mental health diagnosis also in the offing, but that's actually not just across disability, that's even in general health settings. However, I'd just say once again, I used to work in insurance in the statutory classes, personal injury, and there was a saying that there's always a psychological consequence to every injury, and I have to say that I think there's always a psychological consequence to every illness and disability, and that people with lived experience of disability are more vulnerable in every way, and of course do experience higher levels of anxiety and depression. They also experience often higher levels of traumatising behaviour, abusive behaviour and things like that, and that can also have its own understandable psychological consequences. So I think this is one of the other reasons why therapy and counselling is one of the more common things chosen by a lot of people, because no matter what your disability is, the ability to cope with it and integrate it into your life in a positive way is something that everybody needs to be able to do. And I'm really glad that the NDIS is providing the money to let the people create this market which provides these psychological services which are so needed.
Thanks. Can I just say, can we put our hands together and thank Jonathan and David? That was fantastic. I'm now going to call Tina and Liz up, and I'm going to encourage you, please stand up and move around a bit, but don't leave. This is a really unusual opportunity to get really expert insight into mental health, mental illness, NDIS. And so I encourage you, stand up and get active again because it's a long session, but please stay and get the benefit of these presentations.